Hello everyone, this is Dr. Shrikant Gujja, Assistant Professor in Department of Cardiac Anesthesia in UNMICRC Institute of Cardiology and Research Center. Today we discuss about low flow, low gradient severe aortic stenosis. Aortic stenosis is one of the most common valve disorder encountered in clinical practice and one of the most frequent indications for valve replacement surgery. Classically, severe AS has been defined as valve area less than 1 centimeter square or less than 0.6 centimeter square per meter square body surface area, or a mean transvalvular gradient more than 40 millimeters of mercury and peak velocity more than 4 meters per second. Patients with severe AS have a significant risk of cardiac morbidity and mortality and have improved symptoms and reduced mortality following aortic valve replacement. These are the recommendations for measurement of aortic stenosis. This is for transthoracic echo. For LVOT diameter, 2D parasternal long axis view. This measured in mid systole, inner edge to inner edge, and LVOT velocity measured in pulse wave Doppler in apical 5 chamber view. Maximum velocity from the peak of dense velocity curve should be measured. AS jet velocity, this measured in apical 5 chamber view, this measured with continuous wave Doppler, and valve anatomy measured in parasternal short axis view. In this view we see whether bicuspid or tricuspid or quadricuspid, and we will see whether valve is calcified or rheumatic. And this is for transesophageal echo. There are 4 basic TE views for aortic valve. First is the mid-esophageal aortic valve short axis view. In this view, we measure the aortic valve area by planimetry, and the disadvantage of this view is we cannot measure the velocities and gradients through either continuous or pulse wave Doppler. And second view, mid-esophageal long axis view. This view we can use it to assess ascending aorta, LVOT area, and aortic valve cusp. In this color wave Doppler to assess AR, and we can measure the aortic root, and in M mode in infravalvular flow disturbances. Continuous wave and pulse wave Doppler are not parallel in this view. Next view is the transgastric long axis view. This view we can take velocities and pressure gradients with help of continuous or pulse wave Doppler. And fourth view is a deep transgastric long axis view. In this view we can take velocities and pressure gradients with application of either continuous or pulse wave Doppler. In this view we can align the Doppler. Low flow, low gradient aortic stenosis. This entity is found in 5 to 10% of patients with severe aortic stenosis. Low flow defined as a stroke volume index of 35 ml per meter square body surface area, and low gradient means mean gradient less than 30 millimeters of mercury. This characterized by reduced ejection fraction less than 50% and in discordance between valve area, that is less than 1 centimeter square or less than 0.6 centimeter square per meter square. This is the criteria for severe AS, and mean gradient less than 40 millimeters of mercury, and peak velocity less than 4. Actually, there is a discordance between valve area. Usually valve area less than 1 centimeter square usually associated with more than 4 meter per second velocity and more than 40 millimeters of mercury of pressure gradient. So there is a discordance between this. Now we discuss paradoxical low flow AS. Paradoxical low flow, low gradient AS occurs in 5 to 15% of patients with aortic stenosis. It is defined as preserved ejection fraction more than 50% and low LV outflow, that is stroke volume less than 35 ml per meter square, and a small aortic valve area, and a low gradient. The mechanism of paradoxically low flow in face of preserved LV ejection fraction likely relates to high afterload, and reduced stroke volume in this setting is likely an early marker of intrinsic myocardial dysfunction. In these patients, low flow state is generally related to a pronounced LV concentric remodeling with impaired LV filling and reduced systolic global longitudinal strain. Other factors may also contribute to the reduced stroke volume in context of preserved LV EF, including atrial fibrillation, concomitant mitral regurgitation, tricuspid regurgitation or mitral stenosis. These features predispose to a clinical underestimation of severity of aortic stenosis in these patients and delays pursuing appropriate care. The prognosis of patients with low flow, low gradient AS with preserved LV ejection fraction depend in part on presence of symptoms. In series of symptomatic patients, those with low trans-aortic flow had significantly worse prognosis compared with their counterparts with normal flow. Pseudo-AS. What is the pseudo-AS? Pseudo-AS is patients with low flow, low gradient AS may truly have a severe AS with the resultant myocardial failure, that is true AS, or may have a moderate degree of AS unrelated to myocardial dysfunction. In pseudo-AS, aortic valve may appear stenotic as a result of flow-dependent nature of aortic valve area calculation by either invasive or non-invasive technique and inability of myopathic ventricle to generate adequate force to fully open the valve. In pseudo-AS, what is due to LV dysfunction, the aortic valve unable to open fully. So there is an overestimation of severity of the valve. Distinguishing true aortic stenosis from the pseudo-AS. The utility of dobutamine challenge in evaluation of low flow, low gradient AS during either cardiac catheterization or stress echo has been well documented. The inotropic effect of dobutamine results in augmentation of stroke volume. In patients with true AS, this increased flow across the fixed aortic valve orifice results in increased transvalvular velocity and gradients without change in aortic valve area. In contrast, in the setting of pseudo-AS, the augmented flow results in only mildly increasing transvalvular gradient and increase in valve area by 0.2 centimeter square. As many as 30% of patients with low flow, low gradient AS fail to augment stroke volume with dobutamine infusion. These patients are denoted as having no contractile reserve. Distinguishing true AS from the pseudo-AS in patients with no contractile reserve remains challenging. Recent studies demonstrate good correlation between aortic valve calcium score as measured by multi-slice CT scan and severity of aortic stenosis as assessed by the echo. When applied to a patient with low flow, low gradient AS, a calcium score of 1651 units was 93% sensitive and 75% specific in identification of these patients with a truly severe AS. Prognostic indicators. Patients with low flow, low gradient AS continue to have a high risk of adverse cardiac events and high mortality whether their disease is managed either medically or surgically. BNP is a strong predictor of mortality in patients with low flow, low gradient AS. BNP level 550 picograms per ml predicts both overall 1 year survival and 1 year survival after AVR. Clinical approach to patients with low flow, low gradient AS. The current data suggests that patients with low flow, low gradient AS who have a true AS and a contractile reserve on dobutamine challenge should proceed to AVR. The absence of contractile reserve clearly predicts high risk of morbidity and mortality with or without surgical AVR. New modalities may help to further risk stratify these patients and help to guide therapeutic decision making. However, each patient must be considered individually. Clinical approach to patients with low flow, low gradient AS. This is the flow chart how we approach when a patient comes with low flow, low gradient AS. So, low flow, low gradient AS, usually these patients have a low EF, and in low EF patients, whether these patients have a coronary disease or not, we distinguish with coronary angio. In coronary angio, if there is have a coronary disease, so maybe this LV dysfunction may be due to coronary disease, and if there is no coronary disease, we do dobutamine stress echo to distinguish the true AS from the pseudo AS. In true AS, with the dobutamine stress echo, there will be increase in flow across the valve. So, this increase in flow across the valve will increase the velocity if there is a true AS. So, there will be increase in trans gradient velocity and pressure gradient across the aortic valve if there is a true AS. If there is a increase in flow but increase in aortic valve area, but in pseudo severe AS, aortic valve increase aortic valve area will be increased more than flow and gradient. So, by this way we differentiate the pseudo severe AS from the true AS. So, in this flow chart, we'll one more point we discuss about whether patient having a contractile reserve or not, how we decide. So, patients who having more than 20% increase in stroke volume with the dobutamine stress echo, so these patients considered as a contractile patients with contractile reserve. Patients with less than 20% increase in stroke volume will be considered as a no contractile reserve. So, this also useful as a prognostic indicator. Patients with a poor contractile reserve or no contractile reserve have a high risk for surgical AVR, and they have a poor post-operative outcome. Conclusion: low flow low gradient AS poses some important challenges with regard to confirmation of aortic stenosis severity and therapeutic management. A low dose dobutamine stress echo is generally used to differentiate true versus pseudo severe AS and support the indication of AVR in patients with classical low flow low gradient who have a significant flow reserve. The calculation of AVA is helpful in situations where AVA discordance and thus uncertainty about stenosis severity persists at the end of dobutamine stress echo. Aortic valve calcium quantification by CT scan may be helpful to distinguish true from pseudo severe AS in patients with a classical low flow low gradient AS in whom there is no or minimal increase in flow during dobutamine stress echo, or in whom results of dobutamine stress echo are inconclusive. CT is also modality of choice to confirm the stenosis severity in patients with a paradoxical low flow low gradient AS. These are the references. Thank you.